Good afternoon, everyone, and welcome to this Endo ERN webinar. We're really excited to have experts from the Helsinki University and the Helsinki University Hospital making a presentation today on HNF1B diabetes. Just a little bit of housekeeping before we begin. Our experts will make the presentations, and during the presentations, you're invited to put your questions into the question box on your control panel that you have in front of you. Alternatively, you might like to ask your question directly. So at the end, you're free to raise your hand and I will unmute you. I'm Amy Casey and I'm the Communications Manager of Endo ERN. I would like to thank you for attending and also thank our experts for making themselves available to give this presentation to you. I'd like to take a moment to introduce our panel today. Our first presenter is Professor Tiinamaija Tuomi. She's the Chief Physician at the Department of Endocrinology, Helsinki University Central Hospital, and in charge of diabetology. At the University of Helsinki, she serves as the Research Director at the Institute for Molecular Medicine, Finland, and is Vice Director of the Center of Excellence of Complex Disease Genetics from Discovery to Translation. Her research group focuses on genetic and clinical heterogeneity of type 2 diabetes and monogenic forms of diabetes. Our next presenter is Helka Parviainen. She's a radiology with a subspecialty in abdominal radiology and currently works as managing editor in the Finnish medical publication Duodecim. She's also an abdominal radiology in Vaasa Central Hospital, and her research at the University of Helsinki focuses on the radiology of upper abdominal pathologies, especially endocrine diseases and endocrine tumors. Jarno Kettunen defended his PhD thesis on monogenic diabetes 2 years ago and is currently a resident in endocrinology. He currently coordinates the FinModi study focused on monogenic diabetes in Finland, and he's supervised by Professor Tuomi and our next presenter, Professor Parviainen. Professor Parviainen is a specialist in pediatrics and pediatric endocrinology and currently works as Chief Medical Administrative Officer in the New Children's Hospital at the Helsinki University Hospital. Her translational research has focused on pancreatic development and beta cell mass regulation and clinical research on growth and puberty. Thank you so much for being here today, speakers, and let us begin.
Good afternoon and welcome also from our side. I'm Tiinamaija Tuomi and I will start our presentation on HNF1B disease and then, as mentioned, Jarno will continue. Hepatic nuclear factor 1 beta plays an important role during the organogenesis, but it is also expressed in adult tissues. Pathogenic variants in the gene cause a multi-system disease with very varying presentation, which we want to show here. This figure shows the RNA expression in the tissues, adult tissues on the left, and the protein expression on the right, and you can sort of see that it is expressed in a multitude of different tissues. As important, the highest expression level is in the kidney, the pancreas, the gallbladder, and also in the gastrointestinal tract, especially in the colon, which is a little bit surprising because nobody has shown any colonic phenotype in the disease. This figure shows, I will show most of the features, and we will get back to this figure later during the presentation, which will be mainly based on different case reports. So in orange, you can see the structural features, and in white, the functional features in this disease. It was originally found in families with polycystic renal disease and early onset renal insufficiency. It has also been called RCAD, renal cyst and diabetes, but nowadays mainly HNF1 beta related disease, as there are many other features. So the most typical kidney anomalies, or most largely reported ones, are polycystic kidneys, but the kidneys can appear very normal. If you would take biopsies, there probably would be microcysts. They can also be only one kidney or a horseshoe-shaped kidney, or very, very different presentations. And as mentioned, the early onset renal insufficiency is very common, and it can even quite often lead to end-stage renal disease. The kidneys lose magnesium into the urine, and there is hyperuricemia and gout. And the other sort of main feature, well, I'm a diabetologist, so I would call it a main feature, of course, is the hyperplastic pancreas, typically missing the tail and body or just the tail. And this will, in about half of the cases, result in diabetes at some stage, not very early on, not usually in small children. And also it will result in exocrine insufficiency. Further, there are somewhat odd liver enzyme fluctuations. The AST, ALT levels can be some hundreds and then spontaneously normalize. This phenomenon is not, as far as we know, associated with any sort of functional liver problems. However, there are some structural anomalies in the bile ducts, and sometimes there is a cholestasis, especially it seems, I mean, this hasn't really been shown very well, at times of sort of severe stress, as in giving birth or being born or having a transplantation or something like that. Elevated serum levels of parathyroid hormone have been described with sort of normal calcium levels. This has been not studied very well, and of course many of these individuals will also have renal insufficiency, which can affect the levels. In some individuals, especially it seems in those who have a whole gene deletion, which is part of a larger microdeletion in the chromosome 17q, there are some neurological features, some various grades of learning disability, spectrum of autism. We will get back to that later. So if we take our first family, and let's call her Anna. She had been identified with polycystic kidney disease soon after birth, and she had elevated serum creatinine levels throughout the childhood. When she was a teenager, clinical suspicion led to the sequencing of HNF1 beta, and she was found to have a pathogenic missense variant in it, causing the features. When she was a young adult, she was diagnosed with diabetes through increased 2-hour level at plasma glucose or 12 millimoles per liter in oral glucose tolerance test, so very mild, and was treated with just diet. Then she got pregnant, and during gestation week of 16, she was started on mealtime insulin. The pregnancy went well, but the creatinine levels increased a bit up to a level of about 180, and the labor was induced at gestation week of 34. So we moved to her baby. It was a preterm birth, and the baby had a size appropriate for this gestational age. It was actually at +2 standard deviations. At about the age of 2 days, there were respiratory symptoms that led to the diagnosis of renal insufficiency and mild metabolic acidosis, and they were treated in the neonatal intensive care unit. Everything stabilized. The creatinine went actually up to 270. Potassium level was high, and ultrasound revealed small renal cysts that just hadn't been seen in the ultrasound during the pregnancy. And at age about 7, the creatinine is approximately at the same level. The estimated GFR is about 20 milliliters per minute. Here are growth charts of the baby. I'm sorry, you won't be able to see the y-axis, which shows the age, but with the highlighted with the yellow dots, you can see the ages from 5 to 7. The middle curve in black shows the average BMI, and then you can see the curves for +2 and ±2 standard deviations. So the growth was all the time at the -2 standard deviations. The lower figure shows the height as compared to the expected adult height. So how do these pregnancies usually work? We know from, for example, this publication that preterm deliveries are common. I mean, we're discussing mothers with HNF1 beta point mutations or whole gene deletions. So preterm deliveries are common. There's an increased risk of miscarriages, but that could also partly be associated with diabetes control. There has been reported on intrauterine growth restriction. The mechanism is unclear. There are polyhydramnios, and as could be expected, a decline often in maternal renal function. And Dr. Morton with colleagues studied a group of 24 individuals with 17q12 microdeletion, and of those 14 ended up in live births, and 10, actually quite a high number, were terminated, but the reasons for the terminations were unclear. So let's go back to Anna. After the pregnancy, she could stop using insulin, but it was reinitiated a few years later. She came to our clinic about 2 months after the pregnancy, and at that time she had her ALT and alkaline phosphatase were sort of 3 to 5 times above the upper limit of normal. We don't know how they were during the pregnancy, they were not measured. And in an MRI scan, she was found to have a bile duct cyst in the common hepatic duct. What we tend to do for maternal and neonatal screening, let's start with a mother who has an HNF1 beta variant or deletion. And I would point out here that regardless of the clinical presentation at that stage, so whether they have diabetes or not, they should be screened. Of course, if they do have diagnosed diabetes or hypertension, these should be controlled before pregnancy. But those who don't have diabetes should have an early oral glucose tolerance test, and they should be monitored for glycemia throughout the pregnancy, because the risk of developing gestational diabetes is obviously very high. Also, obviously, the creatinine levels, proteinuria, and cholestatic markers should be screened. How often? At least every 2 months, and maybe towards the end of the pregnancy, clearly more often. There has been some discussion about whether pre-implantation or prenatal genetic testing should be performed, but there are no guidelines for that. Then if we think of the fetus of an affected parent, mother or father, of course, we should screen for fetal kidney findings and scan for fetal growth and amniotic fluid volume. We tend to do these screenings as often as for type 1 diabetes. And then after the birth, should monitor for liver and renal function and blood glucose also. And what should we do later in childhood? That, of course, depends a little bit if the child will be genetically tested or not. If the child is also a carrier, or if the status is unknown, there's no genetic testing, then we should follow them clinically, at least blood pressure and renal function, and maybe think of support for neurodevelopmental or behavioral disorders, or at least investigate those depending on the variant that the parents have. So we'll take one more generation of this family, Martha, who is the grandmother of the baby and the mother of Anna. She had been diagnosed with kidney insufficiency and diabetes at least at the age of 20 years, was a multiple dose insulin, which had been started when she was on glucocorticoids for another cause. She had a kidney transplant at the age of 60 years, and then after the transplant was put on tacrolimus-based immunosuppression, and she developed quite a severe cholestasis after the transplantation, but that was reversed. So what about transplantation? What things should we consider? We know, of course, there are no very big studies, but that diabetes will develop in about half of those who did not have diabetes before the transplantation, so it will develop afterwards. There are probably many reasons for that. Of course, there is already a small pancreatic volume and compromised insulin secretion pre-transplantation. And then we know that the calcineurin inhibitors, well, practically all immunosuppressants and glucocorticoids predisposed to post-transplantation diabetes in any individuals through inhibiting insulin secretion. Something that we've discussed is that whether one should consider a combined kidney pancreas transplantation in these individuals. I mean, normally a pancreas transplantation is only performed if one has diabetes or type 1 diabetes before the transplantation, but that's something that maybe could be at least discussed. The calcineurin inhibitors are known to downregulate HNF1 beta, and then of course, if one copy of this gene is already, the function is compromised, then it may be that the people will get more complications. There has been some suggestion that they might be associated with liver problems and especially cholestasis. So at least if there are problems after the transplantation, one might consider minimizing the dose or using alternative immunosuppressants. The important thing is to be aware of the fact that there is an association with these medications and this particular gene. So if we summarize the findings in this family, we can see that all three of them had structural kidney anomalies and early onset renal insufficiency. Anna had also uteral malformation. The bicorn, uterus bicornis is actually quite typical. Both of the women had hyperplastic pancreas. I'm not totally sure whether the child actually, there is imaging data for them, and both had diabetes. There were liver enzyme fluctuations. At least in the grandmother, there was cholestatic disease, and in Anna, there were structural biliary anomalies. So we've discussed these structural anomalies quite a lot, so let's hear now what Helka tells us about how they look like.
Helka,
Okay.
we don't see your.
Yes. Okay, so now everything is fine, right? You are seeing the presentation mode, right?
Yes, thank you.
Great. Okay, so I will show you some images. So I'm a radiologist, so I won't be showing any text, only images. And first of all, this is just a CT image that serves as a graph. So here is the pancreas, and here in another CT plane are the kidneys right here. And finally, the bile ducts are here. So the bile travels from inside the liver from here to the common bile duct, which is here, and through the head of the pancreas. And here is the gallbladder. And what I'm not showing in this image is the uterus, which is of course, another place where we can see the mutations with the HNF1B disease, as Tiinamaija mentioned, and I have some images of the uterus coming up too. So first, let's go to the pancreas. So this is an MRI image, and this is a person who does not have the HNF1B disease. So this is just to give you an idea what a normal pancreas looks like. This is an axial slice of the upper abdomen, and here outlined in red is the head of the pancreas. The pancreas continues through here, but you can't see it because we have to go a little bit up like this. And here is the body and the tail of pancreas. So from here to here, this is the size and the shape of a normal pancreas in a person. So this person has the HNF1B disease, and here is their pancreas outlined in red. So this is the whole pancreas that they have. They have only the head of the pancreas, and there is nothing, no body and no tail. And so this means most of the pancreatic volume is missing in this patient. And this is another patient who also has the HNF1B disease, and the pancreas is here. If you look at it, you can see that it's a little bit narrow, isn't it? And it's also short. The body part is here. So this is the head, and this is the body of the pancreas, but there is no tail. It's supposed to go all the way here. So this is a pancreas that only misses the tail, but not the body. You may also notice the kidneys of this patient here and here, that there's something going on there, but we will go to them in a bit. So this is an ultrasound image of the same patient that we were just seeing, who had the head and the body of the pancreas, but no tail. And in this ultrasound image of the abdomen, the pancreas is here. And this is actually a very typical way of how you see the pancreas in an ultrasound image, because when you look at with ultrasound, you normally can't see the whole pancreas because there is gas in the bowel, and this is the part where there is gas in the small bowel, and it goes right on the way. And it's actually so normal to see that you only see the body of the pancreas, and maybe you could see the head if you went a little bit this way, but it's so normal that you can't see the tail of the pancreas that this ultrasound, which was done before the MRI, was interpreted as pancreas being normal. So what I want to tell you with this is that if you want to know the size of the pancreas, or if you want to rule out pancreatic hyperplasia or pancreatic anomalies, you can trust the ultrasound. Even if you have an ultrasound report that says pancreas is normal, you still can't trust it, because it will be something like this, and it's impossible to say whether the pancreas is short or whether you just can't see the tail. So you should have an MRI or a CT done to this kind of a patient if you want to know the volume of the pancreas. So then I will show some kidneys. So this is the same patient that had the kidneys that you saw the kidney images before, and now these are the kidneys in a coronal plane. The kidneys are of normal size, but there are multiple small cysts. So the cysts are these white spots here. There are like innumerable little cysts on both kidneys. This is sequence in which the fluid is shown as white. So this is these are polycystic, these kidneys. And here's another patient, and here are their kidneys, and they only have a few cysts on each kidney. So here is one cyst you can see here, and another one right here. So there is variation in the kidney findings of these patients, as Tiinamaija told us. And then the uterus. So here is the uterus, and this is a uterine anomaly in an HNF1B disease patient. So this is a bicornuate uterus. This here is the cervix, which is normal. And these are the two cornus of the bicornuate uterus. So normally you would only have one of these, like in the middle, and not two of those. This is kind of a heart shape uterus, and this is another image in which you can see better how the heart shape goes. So this is one cornu, and this is another cornu. So this is the most typical, at least in our patients. And then I will show you finally one image of the bile ducts. This is actually an image from our 2017 publication in which we described this. So in panel A, there is a normal bile duct system in MRI. This is the gallbladder, This is the extrahepatic bile duct, and these are intrahepatic bile ducts here. And in all the other panels, there are different kinds of anomalies that were found in the patients. They are all different kinds of anomalies, but all of them are some kind of cysts in the duct system. So in panel B, there is a large bile duct cyst. So the extrahepatic bile duct here is much wider than this normal one. And in C, there is a smaller bile duct cyst. And in F, there is also a small bile duct cyst right here. And there are, this is an intrahepatic bile duct cyst that has some debris inside it, and that's why it isn't white like the fluid, but black. It's a bit difficult to see possibly. And here, this is a cyst that is associated with the cystic duct of the gallbladder. So there are different kinds of anomalies in the bile ducts, and Jarno will shortly tell us more about these patients. Okay, so this is everything I had to show you, and we can move to the next presenter. Thank you.
All right, thank you, Helka. Can you see my presentation?
Yes, we're on the Radiologist Insight slide.
Excellent.
Thank you.
Thank you, Helka. I'm Jarno, and as you just heard, we did our study in 2017 and assessed our patients with MRI. And of course, it's an interesting finding, but it also raises new questions. It raises new questions. And for example, for Anna in the first family, she has a bile duct cyst in the common hepatic duct. So what is interesting in our patients is that none of our patients had a classic triad of symptoms associated with bile duct cysts. These are jaundice, palpable abdominal mass, and abdominal pain. And of course, because our patients don't have symptoms, we are in an interesting position because generally bile duct cysts are considered pre-malignant, and often they have been surgically removed. But there are some buts in this thing. The first thing is that we don't actually know if the etiology could affect the risk of malignant transformation, because there are two types of cysts. There are acquired and congenital, and it might be that these HNF1B related cysts are not as bad as the other cysts, but we don't know. This question remains open. And the other is something to do with the risk or complications of the surgery, because these are patients that have already reduced pancreatic mass in the first place. So in this procedure, there is an increased risk of developing diabetes or getting even worse dysglycemia than in the first place, because you have to cut a piece of the pancreas. And the other thing is that the technique is a little hard because the pancreas is a little smaller than usually in the first place. So we have to still study these patients to know what would be the recommendation for bile duct cysts. All right, and we will move on. And as you heard from Tiinamaija, there are two types of variants in HNF1B. One is the deletion, whole gene deletion, and one is the intergenic variant. And this case will illustrate you about these differences. So Tim is 20 years old. He has had learning difficulties since childhood. He has been diagnosed with autism spectrum disorder. He developed diabetes at age 15. He's on mealtime insulin. He also has some insulin resistance despite being lean, and he has had stable low levels of magnesium during his life. And as you might remember, the first family had a missense variant, which is an intragenic variant. It's inside the gene, but Tim has a whole gene deletion of HNF1B. So usually this deletion of HNF1B goes with 1.4 megabase deletion in the chromosome 17q12. So Tim has a whole gene deletion. And if we look at his features of his disease, he has some neurodevelopmental features. He has hypoplastic pancreas, diabetes, and exocrine insufficiency. But even though he has some cysts in his kidneys, he doesn't have renal insufficiency. In the end, he's low in magnesium, but creatinine levels are normal. So this brings us to the point that there are intragenic variants in HNF1B that can cause this disease, as in the first family, and about half of the variants are intragenic. For example, missense and nonsense variants. About half of the variants are whole gene deletions, and it includes 15 genes besides HNF1B. It has a size of 1.4 megabases, and the clinical presentation is called 70q12 syndrome or 70q12 microdeletion syndrome. And interestingly, more than half of these microdeletions are de novo, so they are not inherited from either of the parents. And if we go back to the figure of these features, there are some features that are more affected or more severe with those with deletions, and this includes neurodevelopmental disorders. It might be because of some genes that are deleted with these microdeletions besides HNF1B. Also, these patients have lower levels of magnesium. They probably lose more magnesium in the urine, although this is not something that has been studied throughoutly. And at least in patients' cases and case studies, these patients with deletions are more often on insulin than those with intragenic variants. And on the other hand, if you look on those who have intragenic variants, these people have more severe renal insufficiency and they have higher levels of uric acids. So maybe we could give you some tips for the clinics as well. And of course, the first question would be that who should you refer for a gene test for HNF1B? So of course, if you have a clinical presentation that looks like HNF1B disease, and you have a clinical suspicion of that, you can consider having a single gene test for HNF1B. On the other hand, if you have a suspicion of monogenic diabetes in general, you're not sure if it's HNF1B or something else, I will recommend that you should pick a gene panel with genes that include HNF1B. Sometimes diabetes can be the first known presentation in one patient. And of course, if you have family with HNF1B affected by HNF1B, you can also have targeted testing of family members. All right, this is a rare disease network, so how common is it? It's not that common. So if you have a suspicion of MODY, even without renal features, HNF1B disease accounts only for maybe 5 to 6% of the patients. On the other hand, if you go to see a cohort of congenital anomalies of kidneys and urinary tract, you will find HNF1B disease in 1 of 10 patients. Once again, if you have a renal disease of unknown etiology, maybe 1 in 7 patients will have HNF1B variant. There are no estimations on the prevalence of HNF1B intragenic variants, but if we look on the estimations on the HNF1B microdeletions or whole gene deletions, it is estimated that 1.6 patients in 1 million people have HNF1B deletion. This is based on identified patients. But interestingly, from Norway and Denmark, we have some population level estimates, and in population cohorts, it's even up to 1 in 4,000 who could have HNF1B deletion as part of 70q12 microdeletion. So this, of course, this raises new questions that maybe we have a lot of misdiagnosed people with HNF1B disease, or maybe there is a lot of heterogeneity behind this disease. So we don't know this, but if this is true, the disease is far more common than we have thought. So when you have a diagnosis, what should you do next in the clinics? So of course, you should screen for those features and diseases that require treatment or monitoring. Of course, testing for renal function and uric acid levels is important. It's really important. And performing maybe OTTs or at least HV1AC for diabetes or dysglycemia is important. Many of these patients develop diabetes even though it's not 100% penetrant. We suggest that you should screen for structural renal abnormalities at least one time, just to know if there are, for example, just one kidney or if there are many cysts. Screening for hypomagnesemia could be useful, but we have to acknowledge that patients with hypomagnesemia, very often they don't have any symptoms, and treating these patients with supplementation is usually not very successful. Also, biconate uterus is an important aspect, and I think it's important to refer to gynecologist, especially if a patient is planning for a pregnancy, or if there is, for example, a need for intrauterine contraception, etc. And as you heard in the first place, in the first section of this presentation, screening for cholestasis is important at least during the any major stress or pregnancies or post-transplantation state. And last, especially in the patient with 70q12 deletions, we want to keep in mind that there could be need for neurodevelopmental assessment. Also, because if you send a patient to a gene panel of monogenic diabetes, they will answer you HNF1B deletion, but they cannot identify 70q12 deletion in a gene panel, in a normal gene panel. So we recommend that this patient should be also referred to DNA microarray testing if they have a whole gene deletion to detect 70q12 microdeletion. All right, maybe this is a tricky thing. This is a tricky business, how to treat these patients with diabetes related to HNF1B. So first of all, maybe sooner or later there will be a systematic review on monogenic diabetes and its treatment. But maybe most importantly, there are no randomized controlled trials. So everything is based on patient cohorts, or could I say not that confirmative results. So if you look on these reported patients, you know that most of them are on insulin or progress to insulin treatment, but of course there might be some selection bias, and there is the risk that we don't actually know if some other medication would have been possible. So there are no testing, there are no studies on other medications available. We know that sulfonylureas or rebaclinide could be useful in some cases, and of course, if this delays treatment on insulin for years, it should be considered. Also, the role of insulin resistance in these patients is a bit unclear, because there have been clamping studies that point out that patients with HNF1B diabetes also have insulin resistance, but of course they also have hypoplastic pancreatic volume, so we don't actually know what is the ideal treatment in each case, and it might be maybe different for different patients. And in the end of this section, I could say that there are no studies on SGLT2 inhibitors in these patients, but at least in some selected patient cases, this class of drugs has been used to target hypomagnesemia. So if you have a symptomatic hypomagnesemia that is not responding to any supplements, this is one option to consider. All right, in the end, we could just look something about the interpretation of gene test results. So first of all, nowadays the laboratories classify all the variants they found using file-level criteria. These criteria go from benign to pathogenic. So a variant that is pathogenic for a monogenic disease is causal of monogenic disease, of course, and a benign variant doesn't cause a monogenic disease. But then there are kind of intermediate levels, so a variant can be likely benign or likely pathogenic, or just there in the middle is a variant of unknown significance. And the classification is based on combined data on populations, molecular genetics, clinical and computational data. And the interesting thing here is that the classification can change over time. So this is every time you will get a result from a laboratory, it will be interpretation of that time. It can change, and especially this is true for variants of unknown significance, because maybe 2 years after this day, one WUS can be likely pathogenic and one WUS can be likely benign. So this is not static. The other kind of could I say challenge here is that not every disease, not every gene is the same. So the interplay between each gene and monogenic disease is unique, and therefore the general rules first published in 2015 cannot be maybe used that well for all diseases and all genes. And this is the very reason that we have now gene-specific criteria for different genes that are created by ClinGen expert panels. And there are some criteria, gene-specific criteria for genes of monogenic diabetes, but not for HNF1B yet. And this is one of the reasons that you will maybe find some WUSes coming from HNF1B, but this is not because these variants are necessarily kind of soft or not relevant. It's because the evidence hasn't accumulated yet. So just it's good to keep in mind that WUS can be clinically relevant. So in the end, as our concluding remarks, we like to keep in mind that HNF1B could be the gene that is behind a multi-system disease, often with structural anomalies, especially in those who have early onset kidney disease, diabetes, exocrine pancreas insufficiency, hypomagnesemia, and so on. I think it's an important disorder to keep in mind. And we also call for multidisciplinary assessment and follow-up because there are so many organs that are affected. And it's good to keep in mind that family members can be affected as well, although around half of the variants are de novo. There are some special cases that occur, for example, during pregnancy and post-transplantation. I think these special moments needs more careful follow-up than usually. And in the end, it's good to keep in mind that variant of unknown significance can be clinically relevant. And this is our short presentation on this topic. Thank you. And just in the end, I would like to promote AS meeting next autumn in Helsinki. This is targeted for young endocrinologists and scientists, and please be welcome to join September 2024. More info will come. Thank you for attention.
Thank you very much for these presentations. I'm sure that they were very informative for our audience. While we wait for some questions and hands to go up, you're very welcome to ask questions. Either type them into the question box on your panel or put your hand up and I will unmute you so that you can ask your question directly. While we wait for people to gather their thoughts, if you wouldn't mind entertaining a question from me, you made a comment that patients who have the monogenic diabetes, that's an indicator that you should test them for this diabetes. Are there any other conditions that these patients are living with that may be the HNF1B, but are presenting as something else? Can you comment on that?
Maybe just to clarify on the comment on the monogenic diabetes is that clinically these patients, the diabetes often, if it's the only presentation and none of the other features have been noticed, they may just look like they have some kind of a partly insulin deficient diabetes, but they don't have type 1 diabetes, which makes a suspicion of MODY or monogenic diabetes. And in those cases, we just think that there are several gene panels that include like 20, 30 genes that also HNF1B should be included in there. But in those cases, of course, if they present with, let's say, kidney disease or something like that, then it may be more easy to guess that it might be HNF1B to start with. But whether there are other such examples, I can't think of now. Can you, Jarno?
I think it's always it's a combination of features that you have to take into account. And some people have maybe just a few features. There are some risk scores published also for HNF1B that you can use as an aid whom to test. I would keep these in mind if you have a kind of a multi-system disease of unknown etiology. I'd say that.
Although maybe as a bit of a warning, we still may say that regarding many so-called monogenic diseases, there's a lot of sort of a circular references. Like, for example, when HNF1 beta disease was found in families with early onset cystic kidney disease, and renal insufficiency, then doctors would only look for HNF1 beta in such families, and they would not find it in any other kind of families. So it's quite possible that the heterogeneity of the disease actually is much, much larger, and we will only notice then when there will be more sort of unselected screening. So it's quite possible that they all might not be so severe, but I mean, that's something that we will see in the future.
Very good. I mean, to your point about the prevalence and that it is a rare disease, I was just curious about that aspect as well, and perhaps the audience was. I must say that today we do not have any questions. I think it was quite a thorough presentation, and you covered all of the bases. It may be possible, if you think of something afterwards, please email us directly, and we can put your question to the speakers. But in the meantime, I would like to take this opportunity to thank you for such excellent presentations, and to the audience, thank you for attending. And with that, I will bid you good day. Thank you so much.
Thank you very much for organizing this.
Have a good day.
Thank you.
Thank you. Bye-bye.
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 Bye-bye.